Hello, in this lecture, we're going to look at blood flow physiology. I wanted to start with this slide because I couldn't remember if I had it on the last lecture or not. So just a quick comment, when we look at the distribution of blood, if you were to take a sample at any given moment, notice that most of it are in the veins. We mentioned that the veins are able to stretch. They're called the capacitance vessels because at any given time, your blood is there. They're also the lowest pressure. So their walls, remember, were distensible to stretch. Now you're not memorizing these percentages, but just know at any given moment, most of the blood is in a vein. So when we look at the physiology of blood flow, there's a few things we have to review. One is just the velocity, like which vessels have the greatest or fastest flowing blood. And we touched on this previously, but remember that those big arteries are going to have the fastest flowing blood. If you look at this graph, notice that the slowest flowing blood is in a capillary. Remember, we want the slowest flowing blood to be in a capillary because that's where the tissue exchange occurs. Capillaries had the thinnest walls. They only had the tunica intima, whereas your arteries are going to have your thicker wall. They have a really thick tunica media to handle all that pressure. And veins, remember, have the they have thinner walls, not the thinnest, but they have thinner walls than those arteries. They do have, the veins and the arteries all have all three layers. In these graphs, you can notice the vessel diameter. So we know the capillaries are the smallest diameter, right? They're the tiniest vessels. If we look at total area, however, the capillaries are the most numerous. And so what happens is the blood flows, think of the aorta like a river or a highway. So it's flowing through, right, the giant river, and then it branches off into many arterioles. And then arterioles all branch into many, many, many capillaries. So they are the most numerous. Then this blood exchanges with your cells and it returns back through the venules and then finally back into the veins. And if we look at the blood pressure, notice the pressure falls the further we get away from the heart. So technically, we're looking at the left ventricle. Remember, when the left ventricle contracts, that's going to eject blood into the aorta, and the aortic pressure will be equal to the left ventricular pressure. But as that blood flows from the arteries, arterioles, to the capillary beds, to the venules, it falls. So your lowest blood pressure would be in a vein, specifically in your vena cava, and your highest blood pressure will be in arteries, specifically the aorta. So the pressure falls as we flow through the circuit. So let's look at pressure. The important number you probably always hear of is your arterial blood pressure. So this is the blood pressure in an artery. This is what we measure when we measure blood pressure. We put this cuff around and we actually are looking at, this is the brachial artery here. And so remember that every time that the heart contracts, the blood hits the artery and it stretches slightly. And then you have that recoil, that rebound. So your diastolic is with a recoil and then the heart stretches and relaxes and stretches and relaxes. And that's what you feel as a pulse wave through your body. But you can also measure the pressure inside that vessel. And so what we do when we measure blood pressure is we use a special cuff to constrict the blood flow. And then we release the pressure in the cuff. And then once the blood goes through the blood vessel, we know what the pressure is because we know at what point that cuff, what number the cuff is at. And we can hear it. We'll hear bump, bump, bump. So the first sound you hear when you take a blood pressure is the systolic. And then it goes through different phases, and then it actually goes away when the flow is smooth. You can't hear it anymore. And when it disappears, that's showing you the pressure during diastole. There has to be pressure here because it needs to propagate it through the vessels. So when we're looking at our blood pressures, our systolic is basically telling us the pressure in our aorta because that's where it all starts off the left ventricle. And a typical number is 120, and we use millimeters of mercury. That's what Hg is. The reason they use mercury is because in the past, if you've ever seen the columns, they might look like this. You'll see the mercury inside. Mercury is pretty heavy. It's like 6 times heavier than water. And so we use mercury because that's the amount of pressure you needed to raise that silver mercury column. In fact, the pressure of 120 millimeters of mercury in our blood vessels, it's enough to actually shoot blood about 6 feet. So for one thing, we'd have to have one of those blood vessel columns 6 feet tall just to measure 120. And then if you're fascinated by crime scene details, when they talk about blood spatter, if you cut an artery, expect it to shoot at least 6 feet. That's if your pressure is 120. Now notice on the left side of the heart, it drops. You'll see anywhere between 10 and 15 for the pulmonary arteries. Remember, these are the lower pressure just going to the lungs. So it's the left side of the heart that has all the high pressure. The diastolic blood pressure is the pressure inside the blood vessel when the ventricle relaxes. So ventricle contracts, systolic, diastole, it relaxes, and it's usually around 80. So typically you might see numbers like 110, 70 to 110 is what it might be more commonly in females, and males might be closer to 80 to 120, but you get the gist. So we'll just say 70 to 120 is a normal systolic measurement. Let me try this again. If we're looking at systole, we're looking at the 110 to 120. And if we're looking at diastole, we're looking at the 70 to 80. So these are typical ranges you might get when you do a blood pressure, and that's perfectly fine. But remember that if our pressure starts to go up, it means there's usually more resistance, right, in our pipes, and our heart has to work harder and harder to overcome that resistance. Now, the pulse pressure, it's called the PP, is the systolic minus the diastolic. So I'll use the 120 and the 80. So if I take 120, that's my systolic, and I subtract 80, that gives me a pulse pressure of 40. Now, that pulse pressure is really important because it's basically the difference between these two measurements. So it's showing you the difference between the stretch and the recoil. If they're equal, that means there's not much recoil, which is not good because the recoil kind of snaps it through. And the recoil also helps some of that relaxation phase helps a lot of that blood to go into the smaller vessels. So we look at blood pressure, again, we know it's highest in the aorta. It falls as we go through our circuit, so it's lowest in the vena cava. Notice on the capillary, right, the arterial brings blood to the capillary, so it's a little higher on the arterial end. As it goes through, the pressure falls, so it's lower when it leaves at the venual end. And we can see our systolic and diastolic pressures here. Now, another measurement that's pretty important is called the MAP, and the MAP is the mean arterial pressure, and you can see the formula here. And so this one gives us really important information. One, about tissue perfusion. We call this runoff, which I was alluding to with the pulse pressure, when we're looking at the ability of the blood to flow into the smaller vessels, and also your resistance, your total peripheral, resistance, which a lot of times is atherosclerosis, right? We have blockages inside our blood vessels, and when you narrow that lumen, you're going to create more resistance. And so the way you would calculate this is you use your diastolic blood pressure. So in the example here, we have someone who has a pressure of 120 over 90. So the diastolic is 90. The pulse pressure is the 120 minus 90, and then you divide that by 3. And notice that their MAP is 100. Well, if we were to do someone with what we call normal blood pressure, let's check out what theirs would be. So I have to take my diastolic pressure, which is 80, and I have to add that to my pulse pressure divided by 3. And that'll be, roughly 13. So I'm ending up with a MAP of 99. So notice a pressure of 120 over 90 has a higher MAP. That means there's more resistance to flow. So it's a good predictor of atherosclerosis. In fact, a lot of times people will say that the bottom number, the diastolic number, is more important. And it kind of is because, we know that the systolic is when the ventricle contracts. But if you have a lot of resistance to flow, if you have a high pressure when the heart's relaxing, when the left ventricle relaxes, there's a problem in your blood vessels. And it's usually because there's some sort of occlusion going on in there, atherosclerosis. Now, another pressure we're going to look at later is capillary pressures, which you've learned about before. We know if we look at a capillary, we have two pressures. We have the hydrostatic pressure, which is always pushing things out, and then they have the opposite pressure, which is osmotic pressure, which is always pulling things back in. Now, we know that the hydrostatic pressure is always pushing things out, and the hydrostatic pressure is really dependent on the blood pressure. So if the blood pressure goes up, so does the hydrostatic pressure. Well, we know that the osmotic pressure pulling things back in is really dependent on the plasma proteins. And you might remember that the most abundant plasma protein was albumin. Albumin is made by the liver, and it's one of the most important factors maintaining osmotic pressure. So it's helping to get fluids back in your blood. It's preventing edema. We don't want them to accumulate outside of the cell. And we'll come back to that in one of the later lectures. Now, the last thing we need to talk about to set up our talk on blood pressure is resistance. I've been alluding to this so far. There's friction. When the blood flows to the vessel, it encounters friction. So if the friction goes up, so does the resistance. So we have TPR, total peripheral resistance. Remember, that's what contributed to afterload when we studied stroke volume. We don't want this to be high, right? We don't want to have a lot of resistance to blood flow. We want it to be low. Well, there's three main factors that cause this resistance. One is how thick is your blood viscosity. So we have a direct relationship between viscosity and resistance. If your viscosity increases, so does your resistance, and resistance is a capital R. Well, your vessel length, if you have to flow through a longer tube, imagine blood flowing through two tubes here. Well, this longer one, it's going to have more resistance because it's just longer, right? It's going to come in contact with the vessel wall. So the longer the blood vessel, the higher the resistance. Now, the one we star is the diameter, because you don't change your viscosity and your vessel length very often, but the diameter is critical. And a lot of times when we talk about diameter, we use small r for radius. So remember, if you have a circle, the diameter is all the way across and the radius is basically half. So it's very similar. And when we look at radius, it's critical because what we know is that it's not a linear relationship. We know that we have an inverse relationship, and it's actually exponential. Okay, and I'll get to that in just one second. Now, we can hear resistance sometimes if you listen with a stethoscope. Sometimes you can put it on the common carotid arteries and you can hear a noise called bruise, and that's showing there's a lot of resistance to flow in that vessel. So when we look at resistance, the three main factors are the viscosity. Now, again, that doesn't change a lot, but if viscosity goes up, we know we have more resistance, which means we're probably going to have a higher blood pressure to force that blood through. Or if our blood is thinner, our resistance decreases. We know that our longer vessels are going to cause more resistance and shorter decrease it. Well, again, I mentioned we don't change viscosity and length that often. Now, viscosity can definitely change if you're dehydrated. That would be a factor, right? As far as length, not too much. When we gain weight, though, we increase vessels. Adipose tissue, fat is very vascular. So it's been said that for every pound of fat you gain 300 miles of blood vessels. That's a lot of blood vessels. Remember, we have about 60,000 blood vessels total in our body. But the one that we really look at is radius, because that can change fast. So we can vasoconstrict. Notice we can decrease the radius. So if I decrease, little r is radius, that will increase resistance, which is big R. Okay. Or I can open it up. And if I open up the vessel, now what's going to happen is I'm going to increase the radius. So I'm going to decrease the resistance to flow. And so there's actually a more complicated equation that we're not doing the whole thing. If you ever learn of Poiseuille's law, we're going to shorten it. And what we're looking at is flow. So think about flow as blood flow. And blood flow really depends on two things. It depends on your pressure and it depends on your resistance. Big R is resistance. So we know that big R is inversely proportional to radius to the fourth power. So I mentioned that if you take your radius, that it was an exponential relationship. So what that means is that one change in radius is equal to a fourfold change in resistance. That's what exponential means. So radius has a huge effect on resistance. And so if I were to increase my radius, let's just say increase it by a factor of 1, then I'm going to decrease my resistance 4 times. So if we can cause changes to those radius, then we can really affect resistance and we can really affect blood flow. So there's two applications of this to think about. One is if resistance goes up, what happens to flow? So sometimes we use this to control flow in our body. So if I increase resistance, so let's say that I have areas where I might vasoconstrict. Well, if I increase resistance by vasoconstricting, right? We just said that if I decrease my radius, my resistance goes up. What happens to my flow? Well, if F is equal to P over R, and now I'm going to increase R. I'm not changing P, then my flow will go down. And you already know this is how we control blood flow. This is the physics of it. We vasodilate, we vasoconstrict, and then that decreases or increases the flow. So these are things we do when we have active tissues and we want more blood to go there, or when we are cold or warm, and this is how we control blood flow. And my pressure is the same. In fact, it's probably just my normal pressure. That's the norm. Let's look, though, at what happens in disease states. So now let's just look at the whole body, TPR. Now let's say that something has increased my resistance. So I didn't purposely constrict. Maybe I have atherosclerosis. Well, now I need to maintain flow, right? I need to maintain my 5 liters leaving my heart. So if my resistance goes up and I need to maintain flow, the only thing I can change here is my pressure. And the only way I can do that is if I increase pressure. Well, remember, where does the pressure come from? It comes from the left ventricle. Remember, the left ventricle supplies systole and forces the blood out. So if I have high TPR, if I have high afterload in my pipes because I have atherosclerosis or they're not as elastic, then what happens is my heart has to work a lot harder. I have to generate more pressure to push that blood through my pipes. And then when I measure my blood pressure, maybe my systolic blood pressure isn't 120, maybe it's 160 now. And so that's one reason why it's so important to get your blood pressure checked, because you really don't know what it is at any given moment. So this is something I found actually at a physics site to give you an idea of tiny occlusions, right? Tiny amounts of deposits in our blood vessels really affect the pressure. So normally we can circulate blood with a pressure of only 120. Well, look if we're 20% occluded, how high the pressure would have to go. Now, you're not measuring pressures this high, by the way, on the heart. It's not going to be that occluded, and our body will try to dilate. But I just want you to understand how important that relationship is between that radius and our pressure that has to overcome that resistance. So in our next lecture, we're going to start really diving into how we control blood pressure and getting a lot more into the physiology of this.